Good morning. I want to thank you all for inviting me to this meeting. I want to appreciate Dr. Mahmoud Abbas and all the pulmonary group in Egypt and Cairo. I'm looking forward to visit Cairo, especially with the new museum. And also, I'm getting some technical support here that I want to recognize Mr. Chris McLuhan. He's making possible for me to record this presentation. So let's talk about new treatments of COPD. Let me give you my disclaimer. Disclaimer is I work with all the companies who makes bronchodilators, and I have an intellectual conflict because I'm the member of the Gold Scientific Committee. In 2025, we have gone a long way in COPD. This is part of the 2026 report, Gold report that was released last week. And when we emphasize that the patients in group A who has a diagnosis, they should have long-acting bronchodilators. In patients who had symptoms, the main therapy should be a fixed lava-lamas. And in the patients who had exacerbations and less than 300 eosinophils, also fixed lava-lamas. But a big change is who are those patients who fall in group E? We now recognize that one or more moderate or severe exacerbations are too many in the prior year. So our goal should be to prevent for this to occur and for this to happen. You should start the patient, even in one moderate, should be considered to be part of the group E. And we're going to discuss the follow-up algorithm after we talk about biologicals. Today, we know in this group will be a path for the patients who are in fixed lava-lamas or lava-lama and have more than 100 eosinophils to go to triple therapy. And what we've been able to achieve, if you look at the left side of your slide, is the fact that COPD, when the first gold document was published in 2001, it was placed like the objective should be to relieve symptoms, improve exercise tolerance, health status, reduce future risks like exacerbations, disease progression. And we are achieving that. You see the right side of the slide, that in triple therapy, the long-acting bronchodilators can be associated with a 26% reduction in the risk of exacerbation, a significant improvement in patients' quality of life and able to do more than 100 mL improvement in lung function on top. And we have seen with long-acting bronchodilators and a 30% reduction of all-cause mortality. But despite the fact that triple therapy is able to achieve all this, we still see that our patients on a single inhaled triple therapy, 49% of them develop exacerbations. And if your patient uses a multiple inhaled triple therapy, 62% of those patients develop an exacerbations. And what is emphasized is that these further exacerbations impact lung functions and impact quality of life. And who are those patients who continues to exacerbate? In the left side of your slide, we'll show you these patients are sicker. 54% has severe obstruction. 79% tell us they have an MRC more than 2. They have dyspnea with minimal exertion. 35% require oxygen therapy. Significant number of these patients has concomitant cardiovascular conditions, coronary artery disease, ischemic disease, asthma, diabetes. And the cause, if you look at the use of systemic corticosteroids, 90% has received at least one dose and one prescription, and the corresponding to a mean annual exposure of 73 days. These numbers are really astonishing. But 73% of healthcare providers, they feel, oh, my patient is fine. I don't have to worry. Ladies and gentlemen, our patient is not fine. We need to look at different alternatives because out of these patients, 69% will have one exacerbation, 25 are going to have more than one severe, and there is a risk over the next month, a year, 12 months, that 8% of those patients may die, and may not be only due to cardiovascular, to the lungs, will also be related to the cardiovascular comorbidity. So what else can we do? We know that in COPD, we have airway inflammation, narrowing that is improved with bronchodilators, but the inflammation stays there, and that increases the risk of exacerbation. And mucus hypersecretion is the main challenge that we have, that we see in our patients. Our patients telling us, hey, this medication works fine, but the mucus gets stuck here. I cannot bring it up. The slide on the right side will show you the disruption in the epithelium, that destruction of that epithelium that has patients with COPD, and that impairs the mucus clearance. So you have airway obstruction with a structural remodeling, and there is no current therapy that can address these items. So in these 20 years in the first gold document, we went to have SABAs, salbutamol and ipratropium, to have the LABAs, LAMAs combinations. We went from 2 medications to 28 different medications. We have 8 different delivery systems. So we have gone a long way, but all these medications have the same mode of action. So we need to start looking at different ways. What I want to do is I want to show you some data that will be able to studies done in patients with milder disease. And we're going to look at those patients that we discussed that are already on triple therapy that having severe disease. Over the last 20 years, we have looked at other type of molecules. Can we give medication by mouth? That's how the phosphodiesterase 4 inhibitor, Refumiblast, was developed. The big challenge is that the GI side effects that the patients have. So this medication, significant number of patients cannot tolerate because they develop very severe nausea, vomiting, diarrhea, and although can prevent future exacerbations, it doesn't work. The patient cannot take it. At one point, it was trying to develop MABAs. Those are combined LABAs and LAMAs. And there were several products that none of them turned out to be successful. There was these molecules that could have anti-inflammatory and bronchodilator, and that's how the PDA3 and PDA4 inhibitors were developed. The only molecule that became successful is called ensifentrine. And what this medication does, it has effective bronchodilator by increasing the CAMP that reduces bronchial relaxation. It has significant anti-inflammatory effects because it works in the inflammation type 1 and type 2. Impacts neutrophils, impacts macrophage, eosinophils, lymphocytes, fibroblasts. So it has a broader anti-inflammatory effect. And it has a very unique feature that is at the epithelial cells that, as increasing the CMP, also enhance the CFTR activation and ciliary function. So increases the mucociliary clearance. So this molecule completed phase 2 trials and recently finished the phase 3 trials. So there were 2 clinical studies that were done on Enhance 1 and Enhance 2. The studies were a 24-week because it was a bronchodilator effect, but in the Enhance 1, the studies were looked for up to 48 weeks. And it's important to emphasize that these were symptomatic patients, had to have a CAT score more than 10, but 60% of the patients were on maintenance background therapy and 20% of ICS. Part of the objective of developing this medication by the FDA, they wanted to understand how this medication will work in a treatment-naive patient population. The primary endpoint was lung function, and this showed a significant improvement in peak FEV1, in trough FEV1, in the area of the curve FEV1 in these patients. There's a good bronchodilator effect and resulted in an improvement in patient symptoms. In the Enhance 1, there were more wider improvement that we saw in the Enhance 2. And in Enhance 2, this was probably happened because there were more severe patients that discontinued. So the patients who stay in the trial they were more healthier. So they be part of the trial, they have some improvement. But nevertheless, you put together, there was an improvement in their symptoms. One of the features that was part of the secondary analysis is given this medication with such a broad bronchodilator, anti-inflammatory mucolytic activity, could it be impacting exacerbations? And this study shows significant reduction in exacerbation rate and time to first exacerbation. And please remember, this was a cohort of individuals who did not have a history of exacerbations or enriched for exacerbations. What about safety? There were no significant safety signal and none of the signals that were seen before in the PDA4. There were no GI side effects. So within the gold documented disposition in the 2026 report, in those patients who continue to have dyspnea already being treated with fixed LAMAs, we could add ensifentrine as an add-on therapy. Currently, there are clinical trials going on to look at ensifentrine in those patients being on triple therapy who continue to exacerbate. That will be one group. That will be independent of eosinophils or clinical features. They are studying that in patients with bronchiectasis as a mucolytic, both CF and non-CF bronchiectasis. So I think we have to stay tuned because this new molecule may have a broader opportunities for the treatment in patients with respiratory conditions. So what about those patients we've been talking about? Those patients who are already on triple therapy that continue to exacerbate. I know this slide is too much confusing. I just want to highlight a couple of issues. At the top, you have the airway epithelium, where bacteria, smoke, virus, oxidative stress will be the insults that will result in barrier disruption, basal cell metaplasia, goblet cell in hypersecretion, barrier disruption, all those changes anatomically and histological changes that we see in the airway. These changes triggers a cascade of inflammation. In the left side of the slide will be related to Th1 with neutrophils. In the middle, you can see these alarmins, the TSLP, interleukin-33, that will activate dendrit cells, neutrophils, eosinophils. And on the right, the IL-4, 13, and 5 that also get activated that impact with the neutrophils. What we see at the end of the day in our patients, we see fibrosis, remodeling, wall thickening, and we see mucus plugging and our patient symptoms. So certainly the anti-inflammatory and the biologicals in asthma has changed the disease. The question is, can they impact COPD? And we have now the results of two clinical trials, two different molecules. The one on dupilumab and anti-IL-4 and anti-13, two clinical studies to show the efficacy in reduction in lung function. And with meposulimab, we had a study called METRICS that showed a reduction. And recently, a matinee study will continue that complement that reduction in exacerbations. So let's look at the dupilumab trials. There are two phase 3 trials that were done, the Boreas and Notus. And these patients were invited to participate. They had to be in triple therapy at least for 3 months. They had to have 2 moderate or 1 severe exacerbation, more than 300 eosinophils at screening, and history of chronic bronchitis. These patients were screened and observed for a month, and they were randomized to receive the medication every 2 weeks subcutaneous, either dupilumab or placebo, and they were followed from a year. The primary endpoint is the annual rate of moderate or severe exacerbation as compared with baseline. As you can see in the pool analysis, there was a 30% reduction in exacerbations that significantly further decreased exacerbations compared with patients on triple therapy. And we have now better characterization. For example, in a subsequent analysis, we see in patients with both more than 4 that are more symptomatic or less than 4 less symptomatic. In both groups, there is over 28% reduction in exacerbations. We're also seeing that the type of exacerbation these patients develop, they may be different. In the left side is the whole population. The need of systemic steroids is 29% reduced. And even in patients who have more than moderate or severe exacerbation, it's a 20% reduction in systemic steroids. And it's also a subsequent reduction in antibiotics. So it seems that the type of exacerbation those patients develop, they are much less likely at a different type that don't require antibiotics or systemic steroids. Now, one of the striking findings of these clinical trials were the fact that lung function were further improved. And this emphasized how I was telling you. COPD is a treatable disease. We have improved lung function by 150 mL with bronchodilators. Here we have another 50 mL in improvement in lung function. And this translated the patient has significant improvement in quality of life, and more patients in the dupilumab reaching this magic endpoint of clinical improvement. And this improvement in lung function was seen either former smokers or current smokers, was independent on patient smoking history. And what about safety? Well, we know the dupilumab is being used on over 1 million patients, and this is a cohort of individuals that are older with more comorbidities. We did not see any safety signal. So the dupilumab has been approved by the EMA and the FDA, and in patients who are inadequate control for the COPD with the eosinophil phenotype. What about mepolizumab? So we completed the phase 3 trial with mepolizumab that showed a significant reduction in exacerbations compared with placebo. And if you can appreciate, these prolonged for up to 104 days. You can say due to the problem with enrollment that they had, they asked the FDA if they can enroll for longer time period, and you see the separation in exacerbations continues to be like that at least over a year and a half. And this is similar to the result shown in the Matrix trial that showed 18% reduction, as well as the reduction to the first exacerbation in a patient population with more than 300 eosinophils. They also did see a significant reduction in hospitalization. This was not statistical significant because of how the statistics were designed, but it may be having impact in hospitalizations. And the impact in exacerbations was independent if you had for current smokers and former smokers. There was a reduction based on eosinophils, and this was an abstract of the analysis that we presented at CHEST a couple of weeks ago, that we saw a reduction even on less than 150, less than more than 300, or more than 500. So it's from more than 150, there is a reduction of the rate of exacerbations. As well, if the patients have comorbid condition or no comorbid condition, there is no difference in the exacerbation reduction. The patients did experience significant improvement in their quality of life, and there was no change in lung function up to the year and a half. At the end of the year and a half on the study, that here there was a separation. The patient, the placebo, started declining after week 76. By week 104, there was further decline, while the patients in the mepolizumab lung function remains elevated and improved. This effect was seen independent of cardiovascular comorbidities, and there was not a safety signal. One of the side effects of interest was to look if there was a risk for shingles, herpes zoster. And it was saw that 1% of the mepolizumab had 1.7 in the placebo. So the message here to us is that patients must have their shingle vaccine given. A patient with any kind of comorbid conditions and underlying chronic conditions are at risk for to develop shingles, so we must vaccinate them against a shingle. How this fit now in the goal algorithm? You can appreciate that the patients who have more than 300 eosinophils and more than two moderate and one severe, and these patients have been treated chronic bronchitis, they should be treated with dupilumab, or if not, they have any kind of other form of pulmonary condition, dupilumab will be indicated. There have been other pilot studies looking at what other role biologicals can have. In this ABRA trial, patients received benralizumab while the patients had acute exacerbation. And the objective of the study was to see there were less treatment failures as well as if they needed use of systemic steroids. And it showed there was less significant decrease in treatment failures and significant decrease in use of systemic steroids. There was a publication in New England Journal, the COPD Help, that we use biologicals for 4 weeks or up to 48 weeks in a patient who had an exacerbation already and had more than 300 eosinophils, and the study did not show any benefit or continue in a patient population that had an exacerbation. There was a significant decline in eosinophils, but that didn't result in clinical improvement. There are other molecules, these alarmins, the anti-IL-33. There are phase 2 trials that suggested some improvement reduction in exacerbation that were seen primarily in former smokers. But unfortunately, this year we have seen 3 programs with 3 different molecules, the benralizumab, the itepekimab, and the stogilimab, those 3 different pathways that show that one of the phase 3 trials was negative. And the question is why? All these studies enrolled patients who have a history of exacerbations, have high eosinophils to benralizumab, itepekimab, and stogilimab include all comers with eosinophils and were already treated with triple therapy. I will suggest to you that the challenge that the future studies are going to have lies on the placebo or the control group. Look at this data. This was the metric study, 2015, 2017. The exacerbation rate in the control group was 1.71. Yes, it's an 18% reduction to 1.40. But what happened in 2021 to 2024? The exacerbation rate in the placebo is down to 1.01, and the intervention reduced to 0.8. What this shows, ladies and gentlemen, is that the treatment with long-acting bronchodilator has significantly impacted the disease. And if we need to further impact, we have to take into consideration what is the baseline treatment for these patients. Now, one of the questions is how the biologicals may work. We have data in asthma like benralizumab that they decrease score the mucus, they decrease air trapping, they decrease airway hyperinflation. There is studies with tezepelumab that also show decrease in mucus plugs. Recently, there is a Vestige study with dupilumab, also in asthma, that show by 4 weeks after starting therapy, there is a significant reduction in mucus plugs scores as well as radiological assessment. And we know that mucus plugs in COPD, up to 63% of the patients will have significant mucus plugs as seen in the CAT scans. And we have a recent publication by the COPD gene group that show that patients with higher mucus plug scores have increased risk of mortality, while the patient who had no mucus plug, that is decreased. Other studies have also demonstrated that mucus plug is associated with decrease in lung function. Today, there are studies going on to evaluate mucus plugs with patients with biologicals, and if they mimic the results that we saw in asthma, that will explain why this improvement, not only reduction in exacerbation, but improvement in lung function and subsequent quality of life. So what we have learned, So the new pathways will have to be very different molecules with the phosphodiesterase inhibitors. This is the medication we've been looking for to have an anti-inflammatory, a bronchodilator, and a mucolytic in a single molecule. We're going to have to see more studies as an add-on therapy in those patients on triple therapy that continues to exacerbate, as a mucolytic to improve mucus clearance in patients with bronchiectasis, CF and non-CF. Biologicals are going to be the new frontier for those patients to continue to exacerbate as we further understand what's going on. But it's important to emphasize that COPD is not asthma. A lot of the principles we apply for asthma are not becoming the rule in COPD. One example, in the dupilumab trial, for example, there is no decrease in eosinophils in COPD patients over a year, while the asthma patient has significant decrease. So there may be other mechanisms that we don't fully understand. So I want to thank you as we putting together this puzzle and putting in the last pieces that we need to improve our patients. I think we need to thank the hundreds of investigators and healthcare providers by you all and the millions of patients over the last 20 years. They have participated in these clinical trials and they have allowed us to reach the point that we are now, that demonstrate that COPD is a treatable disease, that we can stop the progression of this condition. Thank you again. Thank you, Dr. Abbas, for your invite. I'm looking forward to see you in person.